Hello everyone, and we are back with our internal medicine series. I am Dr. Hivi, and today we will discuss an interesting endocrinology disease, which is diabetic ketoacidosis. We will bring a real clinical case to connect the clinical signs, reach a final diagnosis, and go through the correct treatment. And if you enjoy this kind of content, don't forget to subscribe to my channel. And let's start with the basics. First of all, what is diabetes? Diabetes is a metabolic disorder characterized by persistent hyperglycemia due to either insulin deficiency or insulin resistance. Now, normally insulin allows glucose to enter the cells, but in diabetes, glucose stays in the blood. And this leads to hyperglycemia, glucosuria, and osmotic diuresis, which leads to polyuria and polydipsia. And since the cells are starving now, the body starts breaking down fat, which leads to producing ketones body. We have two main types of diabetes, type 1 and type 2. Type 1 is most common in dogs and type 2 is more common in cats. In dogs, we usually deal with absolute insulin deficiency, so insulin therapy is always required. Now, what is diabetic ketoacidosis? Diabetic ketoacidosis occurs when there is severe insulin deficiency and increased counter-regulatory hormones, stress, infection, inflammation, and this leads to excessive ketone production, metabolic acidosis, and severe dehydration. And for sure, it's a medical emergency. So now, like always, let's bring a real case. An 11-year-old male border terrier presented with lethargy, vomiting, anorexia, and progressive weakness. And the owner also reported polyuria, polydipsia for 2 weeks, weight loss, and previously good appetite. On physical examination, the dog was depressed, dehydrated, has tachycardia, and cranial abdominal pain. So now we have a systemically ill, dehydrated patient. What should we think? At this stage, differentials include diabetic ketoacidosis, pancreatitis, and renal disease, but diabetes is already highly suspected. Now let's move to the lab findings and start connecting the dots. So we are seeing a severe hyperglycemia, which immediately confirms that this is a diabetic patient. In the urine analysis, we have glucosuria, meaning the blood glucose is exceeding the renal threshold and glucose is now spilling into the urine. And even more important, we also see ketonuria. This tells us that the body is no longer using glucose as an energy source, and instead it has switched to fat metabolism producing ketones. Now, when we combine hyperglycemia, glucosuria, ketonuria, and the systemic illness in this patient, we are no longer dealing with simple diabetes. We are now dealing with complicated metabolic crisis, which is diabetic ketoacidosis. This happens because of severe insulin deficiency, which leads to uncontrolled lipolysis, ketone production, and ultimately metabolic acidosis. Now let's move to the CBC result. We are seeing a mild neutrophilia, lymphopenia, and eosinopenia, and also a monocytosis. This pattern is very typical for what we call a stress leukogram. A stress leukogram is usually caused by increased cortisol release, either endogenous or due to systemic illness. So in this case, the body is under significant physiological stress, which further support that this is not a simple uncomplicated diabetes case, but a more severe systemic condition. Now let's interpret the biochemistry profile. We can see a marked increase in ALKP along with elevated ALT and AST, and also increased GGT. At the first glance, this might raise concern for hepatobiliary disease or even Cushing disease. However, in the contents of untreated diabetes, these changes are actually very common. They are mainly due to hepatic lipidosis caused by insulin deficiency and altered fat metabolism. We also see hypercholesterolemia, which further support a metabolic dysregulation associated with diabetes. These biochemical changes can closely mimic Cushing's disease, but in this case they are secondary to uncontrolled diabetes. Now looking at the urinalysis, the urine-specific gravity is 1.032, which indicates that the kidney are still able to concentrate urine, so this supports a prerenal azotemia due to dehydration, not primary kidney failure. We also see glucoseuria and marked ketonuria, which are critical findings. This confirms that glucose is being lost in the urine and fat metabolism has been activated, producing ketones. So together, these urinalyses strongly support diabetic ketoacidosis. Now let's put everything together logically. We have polyuria, polydipsia, vomiting, depression, severe hyperglycemia, glucoseuria, ketonuria, dehydration, and systemic illness. So step by step, we move from diabetes to diabetic ketoacidosis. This is not just a lab diagnosis. This is a clinical diagnosis supported by physiology and systemic science. Now the question is, why did diabetic ketoacidosis develop? Diabetic ketoacidosis does not develop from insulin deficiency alone. It's usually triggered by concurrent stressors such as pancreatitis, infection, inflammation, or other systemic diseases. And this condition increases counter-regulatory hormones like cortisol, catecholamines, and glucagon, which further worsen insulin resistance and accelerate ketone production. Now let's move to the treatment. The first and most important step is float therapy. After restoring perfusion, we initiate regular insulin therapy because insulin without floats can worsen circulatory collapse. At the same time, we must carefully monitor and supplement potassium because insulin therapy will drive potassium into cells, causing hypokalemia. And also supportive therapy includes antiemetic, gastroprotectants, and treatment of underlying causes such as pancreatitis or infection. Most important clinical points are fluids come before insulin, potassium will drop, always monitor. Not every high LKP is Cushing disease, always check for ketones in diabetic patient. And because diabetes is a common disease, but when it progresses to diabetic ketoacidosis, it becomes a life-threatening emergency that requires rapid and precise management. And that's it for today. I'll see you next week with another internal medicine case. Stay safe.